Hi, welcome to Bree's Science Lab. Today is the first episode in a new series, Pharmacology. So we're going to start with pharmacokinetics. This is the first step in learning pharmacology. We're going to cover specifically absorption, distribution, and elimination. We're going to see a little bit about the lipid-water partition coefficient, ion trapping concept, drug transfer, such as facilitated diffusion, simple diffusion, etc. We're going to look at drug reservoirs and barriers. We're going to see a little bit about the first pass effect, biotransformation, including phases 1 and 2. We're going to see how metabolism of different ages affect a drug's absorption and distribution. We're going to see some about renal and biliary cycling and also special excretion factors such as breastfeeding. So we're going to look at all of these, and so if any of these concepts are covered in your classes, you can just go ahead and skip right to that part if you'd like. We're going to go in this order here. Starting with absorption. So absorption, we give a drug to someone. We either give it to them orally through an IV or intramuscularly, or it's sublingual under the tongue. All of these routes are going to have different absorption. So for example, absorption is basically how much of that drug is getting into systemic circulation. So if you give a drug in an IV, it's going right into that vein. So it's going to go, all of it's going to go into that systemic circulation right away. So you're going to have 100% absorption with IV. Sometimes this will also be called bypassing absorption. I think that's kind of a deceiving word. I like to say that 100% of it is absorbed. You also have intramuscularly, and this is not going to be 100% absorption. This is going to have a lower rate of absorption. You're also going to have orally. This is one of the lower rates of absorption because you're going to have to ingest it. It's going to have to go through your gut. It's going to have to go through your liver and everything before we can even get to the distribution part of the drug. And so that's going to have a huge effect on how much is actually getting into your circulation. Now we're going to go to distribution. Distribution is, okay, the drug's in systemic circulation. Now, how are we going to get it to that target tissue, right? We have an idea in mind of where we want that drug to go. And then we have elimination. Elimination is we're getting rid of that drug. We don't want it to stay in our system. We just want it to do its job and then get out, right? So this is how we eliminate it from our bodies. And our main elimination organs are going to be our liver and our kidneys. So our kidneys is what makes urine, right? And that's going to be how we mainly get that drug out, is through our urine. But there's other special cases that you'll probably learn in your class, such as doxycycline, and that's eliminated fecally, so that doesn't really go through the kidneys and into the urine. So there's special cases like that, but your main elimination organ is going to be that kidney. And the liver, which does, everything, it's going to be a big help. It's going to be a big help in helping the kidney do that. So the first factor affecting absorption, right? What affects absorption? And now the main thing, if someone asks you, what is the main factor affecting absorption? Your answer needs to be the lipid-water partition coefficient, right? Because we ingest a drug or we get it intramuscularly, and then it needs to get across a membrane. It has to get inside of that cell. How does it do that? Right? Well, it has to be lipophilic, and lipophilic means lipid loving, and so that also means it's going to be hydrophobic, water fearing, right? So if something's lipophilic, it's hydrophilic or hydrophobic, my apologies, and we want it to be lipophilic. It needs to be lipophilic to cross that membrane. It's also better if the drug is small. It's a small molecule. Sometimes shape can affect it, and it can also be affected, only non-charged molecules can cross the membrane. It has to be uncharged. So the lipid-water coefficient, how this is determined, is actually using a centrifuge tube or a separatory funnel, anything like that in like a lab is basically how that lipid-water partition coefficient is going to be determined. So for an example, if you can see it, we'll do it right here. We're going to have kind of a funnel like that, okay? And we're going to pour water into it up to that line. And then we're going to pour an oil, all right, above that. And now water and oil, you know, those separate, they do not mix. Then we're going to put the drug in there, and we're going to just like shake it all up until everything is just all homogeneous, and then we're going to basically let it settle again, and then we're going to open a little spout right here, and we're going to let all of the water flow out, and we're going to then stop it and close it again once all of the water's out and we just have oil in here. Then we're going to measure how much of that drug is still in the oil versus how much came out of the water. And how much is in that oil determines how lipophilic something was. And so when you're determining this, you put how much of was in the oil, and then you put your division line, and then under that you're going to have how much was in the water. So the higher the lipid-water partition coefficient, the more lipophilic that drug was. And that's what we want. We want a lipophilic drug. And then we're going to go to ion trapping concept. So you're definitely going to go over how a drug is going to be usually a weak base or a weak acid, right? Now, we already said a charged molecule cannot cross a membrane, right? It cannot cross a membrane so readily. So if you have a weak acid or base, it crosses the membrane, but then say it crosses into a super acidic environment, right? If it's a weak base and it goes into a super acidic environment, it's going to get trapped there, because now that basic drug is going to have a charge, so it can't go back across that membrane. It's going to be trapped. Same with an acidic drug, it's going to be trapped in a basic environment, because then as soon as it gets across into that basic environment, it's going to have a charge, and a charged molecule is not going to be able to cross that membrane readily. Then we're going to go ahead and we're going to talk about a little bit about drug transfers. So how does it get across the membrane, right? You're going to have simple or passive diffusion. You probably learned about this in biochemistry, biology. Simple or passive diffusion goes down the concentration gradient. So say you have 50 molecules outside of your cell's membrane, and you have 3 molecules inside the cell's membrane. That's going to have a higher concentration gradient outside than inside. So it's going to flow down inside of that cell. So it's going to flow down its concentration gradient. It's not going to require energy, and it's not going to require any carriers. It doesn't need help. It just does its job on its own. Then we have facilitated diffusion. Now, facilitated diffusion, it's still going down that concentration gradient. It's going to go wherever it needs to. Wherever there's a less amount of that drug, that's where it's going to flow. But, you know, it's not as lipid soluble, you know, it kind of has a charge, whatever. It's a little big. It's going to need help from a carrier to get across. So we're going to invite a carrier to come help it. Now, the thing about carriers is this means that it can be saturated. So what does that mean? So say we have 5 molecules, right, of a drug. So we're going to have 1, 2, 3, 4, 5. And those 5 drugs need help getting across the membrane. They're going to need that help from the carrier. But you only have 3 carriers. So you have a carrier for this one, you have a carrier for this one, and you have a carrier for this one. Well, you only have 3 carriers. All of those carriers already have 1 molecule, so they're saturated. If you need more carriers, if you want these other 2 drugs to get across, or you're going to have to wait until these carriers cross the membrane and then come back, right? So that's what it means by saturated. And then you're going to have active diffusion. This is the last way we're going to talk about. Active diffusion requires carriers, again, so it can be saturated. It's also going to require energy. Why? Because it is not following its concentration gradient. So you have 3 molecules inside your cell and 50 outside your cell. It's going to want to go outside that cell. So those three are going to need a lot of energy to go against their concentration gradient and go outside to where you already have a ton of molecules. And that is basically everything you want to know for drug transfer, at least a brief overview. Then we're going to go to drug reservoirs. This is just a very important thing we're going to highlight. We're not going to delve too deep into it, but drugs can stay in your body. They can stay in your body for months. Certain ones, they stay there for a super long time. And they can stay in fat, they can stay in bones, they can stay in different reservoirs. Now, it's important because say it stays in your body for months, right? You don't want to give that drug every day because it's going to build up in your body and none of it's getting eliminated. It's just staying in there. You can't keep giving that drug, right? They're going to have an overdose. They're going to have too much in their body. It's not going to be handled properly. It can also be a problem when we have a medicine such as doxycycline. Doxycycline is a cyclin medication, and we do not give that to pregnant women, right? Why? Well, it is absorbed into the bone and it stays in the bone. Bone is its reservoir, right? So you don't want to give cyclins to pregnant women because then once they give birth, the baby is going to probably have yellow lines going across their teeth. And that's because you can see where that drug stayed in the bone that was developing. So you also have to be careful with any developing bones. You don't want to do that. It can make them brittle. It stays in there. It can yellow them. And that's just no fun. But other things like that, it can stay in fat, it can stay in muscle, like we said. It can just stay in the body and stay in circulation for months. Speaking of barriers, so we mentioned you can't give a cyclin to a pregnant woman, right? And why not? That's because the placenta is not a barrier. So we have to be very careful because a developing embryo is going to have, it's developing. It doesn't have what an adult human has. And that placenta is not a barrier. So whatever drug you give the mother, that drug is going to go to the fetus. Now, that's why it's so important to be sure you're not giving a certain drug to a pregnant individual because it's going to affect the baby. And it's always easier, I tell people it's always easier to memorize what drugs you can give a pregnant woman versus what drugs you can't, because you can give only a few drugs, but you can't give a lot. But the most important barrier that we're going to learn about is going to be the blood-brain barrier. The blood-brain barrier is a highly selective barrier. It is only going to allow like the most lipid-soluble drug molecules in, right? So think antihistamines. You have an allergic reaction, you take Benadryl, you get really sleepy, right? At least some people do. That's because it crosses the blood-brain barrier. You have things like hydroxyzine, also an antihistamine, and it's going to cross the blood-brain barrier because it's super lipophilic. But if you just give, a regular drug, it has so-so lipid water partition coefficient, it's not going through that brain because your brain is so protected. It has to be. It's one of your most important body parts, and we do not want just anything getting in there. Now, we're going to go to the first pass effect. So this is very important depending on your pharmacology class. Some professors absolutely love the first pass effect, and it's very important to talk about because it's going to affect the absorption and distribution. You take a drug orally, right? So you take a pill and it goes through your gut and through your liver and then it's getting distributed. Well, your liver and your gut have enzymes that are going to help break down that drug a bit. It's going to affect that drug. It can even biotransform that drug in your liver, right? So you have gut, your gut bacteria and stuff, they have enzymes of their own. So when you take a drug orally, it's going to be affected by those enzymes. And that means a lot less is going to get into systemic circulation and then to your target tissue. So that's very important. That can affect how much of a drug you have to give someone. So that kind of leads us very nicely into biotransformation. Biotransformation is the liver's way of making a drug more water soluble. So we went over this, right? We want drugs to be lipid soluble to cross the membrane and do absorption and distribution. But if we want it out of there, we want it to be eliminated, right? Gone from our body. We are wanting to make it more water soluble because then as it goes through the kidneys, right, it's going to stay in the urine. Your kidneys make urine and it's going to stay in the urine if it's more water soluble. You have other things affecting it like pH of a drug. That's why your urine's pH can be so variable. It can be up to like 8 pH, so that's basic, all the way down to like 4. So it has a huge range because these drugs' pHs can affect that. Biotransformation doesn't just help eliminate it. Sometimes it can retain function, but kind of increase a drug's abilities. So say you have codeine. Codeine can be biotransformed into morphine, which is way stronger, but has the same effect. You can also have a change in effect. Say you have vitamin A, you take it, it's biotransformed by the liver, and then now it's isoretonic acid, right? And that has a different effect. That's like for acne and stuff like that. You can also, it can be inactivated and eliminated from the body. It can be changed. It can be, the drugs can be increased. It can also activate a drug, which is kind of weird, but sometimes when you're given a drug, that drug is more like a prodrug. It has to be activated by the liver first, meaning it has to go to the liver, it has to be biotransformed, and then it can work. But it's not doing anything until it gets there because it's just a prodrug. Now, that leads us to phase 1 and phase 2. So phase 1, this is how we're kind of breaking down a drug, and it's kind of deceiving. It doesn't have to go phase 1 and then phase 2. It can do phase 1 and then 2. It can do just 1. It can do just 2. So it doesn't have to go in that order. But phase 1 is going to be mostly mediated by cytochrome P450, which is very important in pharmacology. And it's going to be mostly oxidation reactions that are breaking it down. So you have oxidation, you have reduction, anything like that, that's going to be a phase 1 reaction. Now, you also have phase 2 reactions, and these are going to be mostly conjugation reactions, which are going to be mediated by transferases, okay? And so you want to, if you're given, say you're given molecules, I don't know if your pharmacology, not all pharmacology classes will do this, but say they give you like something from organic chemistry, right? And they say, look here, you know, you added an OH, you hydrolyzed this carbon, whatever. You want to know, okay, was that mechanism, was that a phase 1 or a phase 2? And then you want to know what mediates that, right? So is it going to be cytochrome P450? Is it going to be a transferase? What degradation is it, right? So now we're going to move on to metabolism. So you have lots of things that can affect absorption and distribution. We kind of already went over it. You have, you know, how much of a drug you give, you know, the more drug you give, the more of effective it's going to have. You have heat. So say, you know, you get like a flu shot and it kind of hurts, and so you rub it and stuff. It's a little hot, it's a little inflamed, but you rub it. That also helps it get distributed. Heat, the amount, sometimes it just takes time. Time can affect it. The shape and the size affects absorption. Lipid solubility affects distribution and absorption. All of these things. But you also have age that can affect it. So your age really is important when it comes to certain drugs, because when you're younger, you know, you're 5, you're 6, some drugs can't be given because some of those kids or even babies, you know, they haven't made certain enzymes yet. So if they don't have those enzymes to break down that drug and eliminate it, you're gonna have to give a lot less of that drug, and sometimes you just can't give it at all. You just can't give it to a kid because they're not able to eliminate it quickly. So that's gonna affect that's going to affect how much of a drug you give, or if you can't give it at all. You also have, say you have 13, 14, sometimes that's in the growth phase, right? Kids just shoot up. If you have kids, you probably know it's like they grow a foot a day kind of thing. Well, their liver is going to grow at an alarming rate compared to their body. Their liver is going crazy. It's growing way faster, right? So that's how I like to think of it, right? And that's going to affect it because the liver is going to be doing extra work, and the liver is going to be breaking it down faster. So you don't really want to go by the size of a kid. Sometimes you have to go by, like sometimes you have to do like weight, like based on a weight. But sometimes you have to look and say, okay, the liver's going to be working extra hard. That means the drug is going to be metabolized even faster, which means you're going to have to give them more, right? Because they're metabolizing super, super quick. They're, it's like how they eat a lot when you're growing, you're also going to have to give more of that drug. You also have things like the elderly. You have to be careful what you give them, because sometimes their rate of eliminating it is going to be lower, like a child. You also have things like liver and kidney failure. So the liver is going to secrete albumin, right? It's going to make albumin, and that's going to bind drugs. And say you have liver failure, you're not secreting as much albumin as a typical patient. So you have to be careful how much you give them, because you don't have as much albumin. Same with the kidney. So you want to be very careful with that as well. Heart failure can also impact that. So if you have heart failure, you're probably not getting as much blood flow, you're not getting as much oxygen to certain areas, so that's going to affect it. You might have slower distribution and stuff like that, so you have to be very careful. All of these are going to impact that. Then you have to make a quick note about enzyme inducers and enzyme inhibitors. So we talked about the first pass effect. We said enzymes are breaking down drugs, right? Gut enzymes, liver enzymes, everything like that. They break down drugs. So if you give an enzyme inhibitor is going to decrease the synthesis or the making of those enzymes, or it's going to increase degradation of those enzymes. So it's gonna like kill those enzymes. It's going to decrease their level, right? Now, if those enzymes are decreased, whether they're dying off or whether they're not being made as quickly, that's going to also influence drug metabolism, because you're going to have more of that drug. You have less enzymes, you have more drugs. So that's also an important note to make before we move on to renal and biliary cycling. So this is really fun. This is excretion. We've now got into the excretion part, right? And the kidneys means renal. So when we talk about renal excretion, like I said, most of your drugs are going to be renally excreted. But if you've ever seen your kidneys, they have tubules, they have nephrons and stuff, and you have to go through. So it's kind of a complicated cycle. Not every class is going to cover this, but in case they do, you're going to have glomerular filtration, active tubular secretion, and passive tubular reabsorption. So glomerular filtration and active tubular secretion is the drug getting into the urine, right? And so things that can affect this, you have pH, you have whether it's bound or unbound, you have everything like that. But only an unbound drug can be filtered into the urine. So remember how we mentioned albumin being made by the liver? Albumin binds drugs. So if it's bound, it cannot be filtered into the urine. It's just going to stay in circulation. So you want it to be unbound, to cross into the urine. And so say it gets into the urine, right? It does that during glomerular filtration and also does that during active tubular secretion. But active tubular secretion, an important note to make is that it has a fixed capacity. So kind of how we said the carriers can be saturated during drug transfer, these have a fixed capacity. They can be saturated, right? Now, passive tubular reabsorption is not the blood to the urine. This is the urine to the blood. So it's like a second chance for the drug. So say it got into the urine and stuff, and then it was like it was working really hard, and it got back into the blood. So it went from the urine to the blood. It decided, I'm actually not done here. I'm gonna come back. That can happen too. Only unionized drugs can be reabsorbed due to ion trapping, right? So we went over that. So it still has to be unionized. It has to be uncharged. And the pH of that is really going to affect what drugs get trapped and what drugs can go back to the body. And that's because, like we said, weak acids, weak bases, if they go into a basic or acidic environment, they get trapped, right? Because they're now charged. So a little bit more in depth would be the biliary cycling. So this is going to refer to very lipid-soluble drugs or phase 2 products. So phase 2 were conjugated, that was conjugation. So you have conjugated drugs or you have very lipid-soluble drugs. Sometimes, right, that's gonna be excreted into the bile. And when it gets excreted into the bile, then the drug is deconjugated by bacterial enzymes in the GI tract. And now that it's deconjugated, it can go right back into circulation. It can stay in circulation. And it's going to do this by being reabsorbed into the portal vein. Because now it's active, it can go back, it doesn't have to leave, right? Thank you, bacterial enzymes, right? They sometimes do good. And that's going to be called sometimes enterohepatic recirculation. That's a fancier way of saying it. I just prefer biliary cycling. But this reduces the elimination of drugs, and it's going to prolong how long they're in the body or systemic circulation, which means they're going to have a longer duration of action. And that brings us to our last little bullet point here. That's going to be special excretion. I just wanted to touch on this because we talked about the placenta and how we have to be careful with pregnant individuals and giving them drugs. You also have to be careful with breastfeeding. So breast milk is actually slightly acidic. That means with our ion trapping concept, that means weak bases are going to get trapped in breast milk, and that's going to lead to a baby basically getting the same drug that the mother is getting, and that's not good, right? Because we went over metabolism. Those phase 1, phase 2 enzymes, they're not done being created yet, right? So you can't give the same drugs to the mother as you can the baby. So you want to be very careful. You want to ask your patient, are you currently breastfeeding? Are you pregnant? That's why you usually get those questions when you go into the doctor's office. And then a last thing to end off on, another special excretion mechanism would be actually pulmonary. So like breathing, you actually excrete things when you breathe out with carbon dioxide. And that's really interesting to me, but you probably already knew this because you've probably heard of breathalyzers. So if a cop suspects someone's been drinking and driving, they get pulled over and they have them do a breathalyzer usually. And why do they do that? Well, drugs can be excreted via your breathing, and alcohol, which is a drug, can be excreted, and that's basically what the breathalyzer is monitoring. So very interesting that's how that works, but that is related to pharmacology. So I hope you enjoyed. This was Pharmacokinetics. The next episode will be on pharmacodynamics, and then we'll get started into drug groups like antihistamines. We'll touch on anesthesiology a little bit, all fun things. But please leave any comments or questions you have down below. I appreciate all feedback, and I will get back to you guys as soon as possible. Please stay tuned for the next episode, and please subscribe if you haven't already.